Good afternoon. I am Professor Michael van Ameringen from the Department of Psychiatry at McMaster University in Hamilton, Canada, and today I'm going to be speaking about glucon-like peptide 1 receptor agonists. Could they be a new treatment for some psychiatric conditions? Before I get started, I want to thank Professor Del for inviting me to be part of this plenary session. The media has been quite outspoken on the benefits of Ozempic. As you can see here on the Economist cover, they state that drugs like Ozempic will change the world. It's not clear that they're going to change the world, but they're certainly going to change a number of potential health outcomes. And if you look at the cover of the New Yorker magazine, they're stating that people have given up their diets to have a Ozempic, and stating that half of Hollywood is now on these treatments to lose weight. So they're incredibly popular, and you can't avoid all the publicity about these treatments. So the objectives of my talk today are to review the pharmacology and mechanism of action of GLP-1 receptor agonists, to review the use of these medications in type 2 diabetes, obesity, cardiovascular disease, and sleep apnea, to examine the risk of adverse effects associated with the GLP-1 receptor agonists, and to examine the current evidence for the use of GLP-1 receptor agonists in neuropsychiatric conditions, including substance use disorders, binge eating disorder, mood and anxiety disorders, schizophrenia, Alzheimer's disease, and Parkinson's disease. This is a list of my disclosures. None of them actually are related to this particular talk. This slide shows the evolution of publications in the GLP-1 receptor agonists. The notoriety has particularly occurred since the release of semaglutide Ozempic in 2021. Approximately 1 in 8 Americans are reported having ever used a GLP-1 receptor agonist. 39% did so to treat a chronic condition. 38% did so to lose weight. About 22 million Americans and up to 1.4 million Canadians are currently taking GLP-1 receptor agonists. I was unable to find any data on the use of these in Italy, but this is a research report on the sales of GLP-1 receptor drugs in Italy, and in 2023 the market was worth about $440 million US, and it's said to go up to $2 billion a year by 2030. So, what are glucagon-like peptide 1 drugs? Glucagon-1 peptide is produced by the cleavage of pro-glucagon. It's an endocrine hormone that's secreted in response to nutrient ingestion and neuroendocrine stimulation. It is synthesized by the intestinal mucosal cells, pancreatic islet cells, and the neurons in the nucleus of a solitary tract. It's an incretin hormone that plays a vital role in controlling human blood glucose levels. It only lasts about 1 to 2 minutes when it's in the circulatory system because it's degraded by dipeptyl peptidase 4. So the glucagon peptide receptors bind either to the GLP-1 peptide or its agonists. They play a role in CNS regulation of appetite, pancreatic regulation of insulin and glucagon secretion, as well as lipid metabolism. As you can see from the diagram on the right, there are receptors in the brain, in the heart, in the lungs, in the GI tract, and in the pancreas. So the mechanism of action is that when GLP-1 is released by the small intestine, it binds to GLP-1 receptors across the body and activate a series of pathways which then stimulate the release of insulin and suppress glucagon to lower serum glucose levels. This makes peripheral cells more responsive to insulin. It slows stomach emptying to reduce appetite. Then GLP-1 travels to the brain to increase satiety and reduce food cravings. Gastric inhibitory peptide is another peptide that's similar to GLP-1. When activated, it also releases insulin after eating, enhancing the effects of GLP-1. It also regulates glucose digestion and acts directly on the brain to promote neurogenesis and control appetite. And some of these GLP-1 receptor agonists have properties of GLP-1, but also of GIP, which seems to potentially have more effect on weight loss. So on this slide, we compare the effect of the GLP-1 to the GIP peptide, and you can see they're quite similar. The GIP receptors are found in many of the same places as the GLP-1 receptors and have many of the same functions and mechanisms, with additional functions that aid in weight loss, diabetes control, and decreasing side effects like nausea. So aside from the effects I've mentioned already, the GLP-1 drugs reduce inflammation, and including neuroinflammation. They promote neuron health. They modulate dopamine levels, affecting the reward-seeking behavior, and they regulate brain glucose metabolism. So in diabetes type 2, the pancreatic beta cells have become damaged, and insulin secretion response becomes blunted or absent. As the cells don't respond to insulin, the pancreas doesn't produce enough insulin to keep up, and they're unable to suppress glucagon release. So it's thought that the GLP-1 drugs work in type 2 diabetes by promoting insulin secretion, suppressing glucagon production, promoting proliferation of the inhibitory apoptosis of pancreatic beta cells, and making peripheral cells more responsive to insulin. And what about the mechanism in obesity? Well, the drugs activate the vagus nerve to reduce stomach contractions, slowing down stomach emptying. They activate neurons that promote satiety and inhibiting neurons that induce hunger. They work on the hypothalamus to regulate energy expenditure and adipose tissue metabolism. And they increase free leptin, and by this they suppress appetite. So we know about the indication for the GLP-1 drugs in type 2 diabetes and obesity, but just recently, at the end of 2024, semaglutide was approved to reduce the risk of cardiovascular death, heart attack, and stroke in adults with cardiovascular disease and either obesity who have obesity or are overweight. So this is based on the key study of 17,000 people, and people who are over 45 have cardiovascular disease and have a BMI of over 27 and do not have diabetes. They were randomized to semaglutide or placebo over 40 months. And what they found was that semaglutide was superior to placebo in reducing the incidence of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke, with a hazard ratio of 0.80. Also, just in the last week, Tirzepatide was approved by the FDA for adults who are suffering from moderate to severe obstructive sleep apnea. And this was based on studies where tirzepatide or placebo was given to individuals who had moderate to severe sleep apnea. In one of the clinical trials, the patients received tirzepatide plus positive airway pressure, or placebo and positive airway pressure. And in the second trial, there was no positive airway pressure. It was just tirzepatide or placebo. In both of these studies, tirzepatide showed significantly less apnea, hypoapnea events per hour of sleep than the placebo group. And this led to the first drug receiving the indication for sleep apnea. So it sounds that these drugs are doing quite amazing things in a number of different areas, but what about the adverse event profile? Well, 40 to 65% of individuals get nausea, diarrhea, constipation, vomiting, bloating, which over time most people are able to tolerate and accommodate. About 3% of people will get gallbladder disease, less than 1% will get an acute kidney injury, and there are rare things like retained gastric contents or aspiration, or reduced bowel mobility and a possible ileus. There are some things such as thyroid cancer and pancreatic cancer that have been concerned, but recent data has shown that there's no increased risk of thyroid cancer or of pancreatic cancer. One of the other concerns has been that's been raised with the European Medicine Agency and the FDA was reports of suicidality. This was studied in a retrospective cohort study investigating the incidence and recurrence of suicidal ideation in those taking semaglutide compared to non-semaglutide anti-obesity or anti-diabetes drug. And so this was examined in a nationwide kind of database in individuals with obesity, with or without diabetes, and no prior suicidal ideation. So they looked at those exposed to semaglutide or 7 anti-diabetic, anti-obesity medications, and they found that semaglutide was seen to have a lower risk of suicidal ideation compared to other anti-obesity or anti-diabetic medication. In another study where they were looking at the reported odds ratio, they found that for suicide attempts, the reported odds ratio was significantly decreased for the GLP-1 medications, and for completed suicide, it was also significantly decreased risk for the GLP-1 receptor agonists. In a study that looked at an active comparator new user cohort study and a registry from Sweden and Denmark, they looked at adults who'd been exposed to either a GLP-1 receptor agonist and compared to sodium glucose cotransporter 2 inhibitors, and they found no association between the use of GLP-1 receptor agonist and an increased risk of suicide, death, self-harm, or incident depression and anxiety related to disorders. And finally, in a study of individuals that had died by suicide or those hospitalized for suicide attempt with at least one GLP-1 receptor agonist dispensed to them within 180 preceding days, they found again that the GLP-1 receptor agonist use was not associated with an increased risk of suicide or suicide attempt. So I think at this point it is fairly safe to say that there is not an increased risk of suicidality or increased suicide attempts or completions with the use of GLP-1 receptor agonists, and potentially it may decrease the risk of these behaviors. So I'd like to move on now to looking at the GLP 1 receptors in neuropsychiatric conditions as a primary treatment outcome. So how do these drugs work in substance use disorders? Well, when you use a substance, it blocks the dopamine transporter, and it increases extracellular dopamine and causing reward and reinforcing signals. The GLP-1 receptor agonists work in the ventral tegmental area or the nucleus accumbens, and there's evidence that GLP-1 receptors regulate dopamine activity by increasing activity at the dopamine transmitter and increasing dopamine reuptake, and thereby reducing extracellular dopamine. The GLP-1 receptors also decrease the release of glutamate. Use of substance is thought to actually increase the release of pro-inflammatory cytokines and activating glial cells. However, the GLP-1 receptors are known to decrease neuroinflammation. So there's clearly mechanistically a profile that suggests they could be helpful in the use in treating substance use disorders. So there are two retrospective cohort studies in the United States that looked at the risk of developing alcohol use disorder, cannabis use disorder. And these are in individuals that were exposed to semi-glutide in studies of diabetes and obesity. And they found that there was a significant relationship between those on semi-glutide and a lower risk of the diagnosis of incident or recurrent alcohol use disorder or cannabis use disorder. So some real-world data that looked at 136 U.S. health systems covering over 100 million patients, and they looked at prescriptions of the GLP-1 receptor agonists, and they were looking specifically at the incidence of opioid overdose and alcohol intoxication. And they looked at the notations in the electronic medical records. And what they found was the patients who had been on the GLP-1 receptor agonist prescriptions had significantly lower rates of opioid overdose and alcohol intoxication. In another study of alcohol use disorder, they looked at 262 adult patients who had a BMI of 27 and were started on either liraglutide or semaglutide. And they looked at their alcohol intake pre and post, and they followed them to 6 months. And overall in the study, they found that there was a mean reduction from 11.8 units per week to 4.3 units post-intervention. And this was particularly interesting in those who at baseline consumed over 11 units per week of alcohol. They had a great intake decrease by 15.4 units per week. The mean weight loss was 7.7 kilograms over 4 months. But interestingly, there was a weak correlation between alcohol reduction and weight loss, suggesting that the effect on alcohol reduction may be independent of the weight loss. In another study of exenatide, which was a randomized controlled trial over 26 weeks, people were randomized to exenatide or placebo, and they looked at the number of heavy drinking days as the primary outcome, as well as total alcohol intake reduced. But they did not find a significant difference between the exenatide group and placebo in this study. But interestingly, when they looked at a subgroup and they looked at the obese patients that had a BMI over 30 milligrams, there was a significant reduction in the exenatide group in reducing heavy drinking days compared to placebo, as well as a total alcohol intake, which was not found in individuals with a BMI less than 25 milligrams Turning to cocaine use disorder in a small randomized double-blind crossover within subject design in 13 individuals with cocaine use disorder. The way this study went, individuals were either pre-treated with exenatide or a placebo for 180 minutes, and then they were given an IV infusion of cocaine of different dosing levels over an hour, and then they were allowed to self-administer cocaine over 90 minutes, and looking at the number of cocaine infusions as well as a visual analog of euphoria and craving. And in this study, the pretreatment with exenatide did not significantly change the number of cocaine infusions compared to placebo, and there was no significant difference between self-reported euphoria or cravings between exenatide and placebo. In another study, there was a cohort study that looked at the association of semaglutide versus other anti-diabetic medications with the opioid overdose risk in patients with type 2 diabetes and opioid use disorder. And they found that semaglutide was associated with a significant lower risk of opioid overdose during the year follow-up in the semaglutide group versus that and other diabetic medications. There's also a small study that was reported last year. It's a double-blind placebo-controlled 3-week trial in 20 individuals opioid use disorder, and they were either given liraglutide or placebo. These individuals were undergoing medication-assisted withdrawal. And in the liraglutide group, they found a 40% decrease in opioid cravings. And interesting, those who were on liraglutide with buprenorphine had a greater likelihood of having no cravings compared to the control group. And this, suggests potentially a signal in the treatment for the use in the treatment of opioid use disorder, and particularly with combining with buprenorphine. So turning to nicotine dependence, there's a randomized control trial of dulaglutide versus placebo over 12 weeks, and there's about a 20% dropout rate. In this study, smoking abstinence rate declined in both groups, but were not significantly different. In a secondary analysis of this study, they looked at those who were consuming alcohol at baseline, and they find that after 12 weeks, those in the dulaglutide group had a 29% drop in their drinking compared to the placebo group. So suggesting that the effect of reducing alcohol may be independent of any effect on smoking cessation. In another study looking at nicotine dependence, there was a nationwide database that was evaluated with patients with type 2 diabetes and a comorbid tobacco use disorder, and they looked at those exposed to semaglutide versus 7 other anti-diabetic medications, and they found a significant decrease in tobacco use disorder in those who were exposed to semaglutide with or without obesity. So turning to binge eating, there's a randomized controlled trial looking at 44 obese individuals who had subclinical binge eating disorder who were randomized to liraglutide or placebo for 12 weeks. They looked at self-report binge eating scores, and in this study they found that the liraglutide group had significant reductions in binge eating scores, body weight, BMI, systolic blood pressure, and fasting glucose. But they also found a reduction in the placebo group. However, what was unfortunate in this study is they didn't make a comparison looking at the group differences between the two, suggesting that it may be beneficial for binge eating disorder, but not clear, as the placebo group did also get some response. In another pilot study that looked at individuals who had type 2 diabetes and binge eating disorder who were randomized to dulaglutide or gliclazide, a sulfonylurea anti-diabetic drug over 12 weeks. And they found that the weight, the BMI, percent body fat mass, binge eating scores were significantly reduced in the dulaglutide group and not in the gliclazide group, suggesting effect on binge eating with this medication. In a small randomized controlled trial of liraglutide in binge eating disorder compared to placebo, there was no significant difference between the placebo group and the liraglutide group, but quite a small study. And there was no significant difference in those who achieved remission of their binge eating between the placebo and liraglutide in this study. In a retrospective chart review of 98 patients with obesity, they were randomized to either semaglutide, to an anti-obesity medication such as topiramate or lisdexamfetamine, or the third group was semaglutide plus one of these other weight loss drugs. And in this study, both of the groups that had semaglutide had significant improvement in binge eating disorder compared to those who were just on a weight loss medication. And interestingly, there was no difference between the two, the scores on the binge eating between the two groups who were on semaglutide. So it didn't seem to matter if you had the additional weight reduction medication in this study. So I want to move on to talk about mood and anxiety disorders and GLP-1 receptor agonists. So there's data from a cohort study of electronic medical records looking at those exposed to the GLP-1 receptor agonists compared to those who had not been exposed to these drugs. And this was examined in these very large data sets. And they found that the cumulative incidence of anxiety was 2.13% lower in those exposed to GLP-1 receptor users than non-users. However, the incidence of depression was not significantly different between groups. So it looks like here in this database that the dulaglutide showed a signal for reducing the risk of anxiety, but not of depression compared to non-diabetic medication. In a meta-analysis that looked at 5 RCTs and a prospective cohort study that were done in people with type 2 diabetes and Parkinson's, and they looked at change from baseline in the depression rating scores, they found that they decreased significantly when patients were treated with these GLP-1 receptor agonists compared to a control treatment. However, I think the confounding factors in this study could have been related to the alleviation of diabetes or Parkinson's symptoms, which could have led to the lower depression in this study. There's a systematic review of 4 studies that looked at type 2 diabetes with depression ratings. 2 of the 4 studies showed no evidence of the GLP-1 protecting against incident depression. However, in one population-based longitudinal cohort study, they saw a decreased risk of depression and anxiety in those using GLP-1 receptor agonists. And in another study, they saw a risk reduction in the effect of depression with dulaglutide, but not with some of the other GLP-1 receptor drugs. So very minimal data set in terms of the use of GLP-1s for depression. There is one study that was looked at in schizophrenics who were treated with antipsychotics and had a BMI greater than 30. They compared exenatide to placebo in 20 individuals, and the primary outcome here was the brief assessment of cognition in schizophrenia and the composite score. And here they found no significant effect of exenatide on the cognitive functioning test in schizophrenia. Certainly, psychotropic medications are known to cause weight gain and lead to individuals stopping medications. The use of GLP-1 drugs have been studied in this population. There is a systematic review of 6 studies investigating weight loss, and in those on these psychotropic medications. Most of the studies found reported a significant and clinical meaningful effect of the GLP-1 receptor agonist on weight loss, with an average weight loss of 3 to 5.3 kilograms across these 6 studies. I want to turn now to talking about Parkinson's and Alzheimer's disease, looking at these neurodegenerative disorders that are characterized by motor symptoms in Parkinson's disease and or dementia in Alzheimer's disease. The pathogenesis involves neuroinflammation, neurodegeneration, and a buildup of proteins, the alpha-synuclein in the Parkinson's, and amyloid beta plaques and tau tangles in Alzheimer's. GLP-1 receptor agonists have mechanisms that reduce neuroinflammation, promote neurogenesis, and there is some evidence from animal models that they can reduce the accumulation of alpha-synuclein and amyloid beta proteins. So I want to start off by looking at Parkinson's disease. This was a single blind proof of concept trial of Parkinson's disorder where individuals were randomized to exenatide or placebo over 12 months. The primary outcome for this study was a change in Movement Disorder Society Unified Parkinson's Disease Rating Scale. And this is a score of a scale that measures motor disability. In this study at 12 months, those that had been on exenatide had an improvement in their mobility measure, while the placebo individuals had a decline. Interestingly, also in this study at 12 months, there was an improvement in the dementia rating scale in the exenatide group compared to the decline in the placebo group, suggesting improvement with exenatide in motor disability and dementia in Parkinson's disease. This same study was looked at. The previous study, they were treated for 12 months, and then the drug was discontinued. This followed the completers another 12 months off drug, and again they found in the group that had been on exenatide a year later that they continued to have improvement in their motor disability measures that was not found in controls, but they also found an improvement in the dementia rating scale compared to the control group, suggesting that there may be long-term post-treatment effects compared to placebo, although again this is a small sample size. Another randomized controlled trial with liraglutide or placebo in individuals with Parkinson's disease. And again, the mobility measures the primary outcome, but they also looked at a non-motor symptom scale. And in this study, after 54 weeks, the non-motor scale significantly improved in the liraglutide scale, but worsened in the placebo group. when they looked at the groups off of medication, the mobility disability measure was no different between the two groups, although there was a significant difference for the PDQ-39 and the Parkinson's Anxiety Avoidance Behavior Scale. So in this study, it suggests that the non-motor symptoms of Parkinson's improved compared to placebo with the liraglutide, but not the mobility measures. There's another a study that looks at exenatide in a randomized controlled trial compared to placebo. Again, the mobility measure is the primary outcome, and people were treated for 48 weeks, taken off drug, and then they evaluated them at 60 weeks. And again, there was a significant difference with improvement in the mobility measured for the exenatide group and a worsening in the placebo group. Moving to Alzheimer's disease, there is a large database that was examined in diabetics with no prior history of Alzheimer diagnosis. This was looked at exposure to semaglutide versus 7 other anti-diabetic medication classes, and they found that semaglutide was associated with significantly less Alzheimer's disease compared to other medications in this large database. In another study, this time in individuals who had mild to moderate Alzheimer's, liraglutide was compared to placebo over 12 months. And in this study, the liraglutide group had significantly better temporal lobe and whole cortical MRI volume. They found a slower decline in temporal lobe and total gray matter volume compared to the placebo group. And on the cognitive test, they found an 18% slower decline in cognitive function at the 1-year mark compared to placebo. So in this study, it suggested that liraglutide may have some effect in preserving cognitive function in those with Alzheimer's disease compared to placebo who were treated with liraglutide. In another a study that looked at data that was pooled from a number of big RCTs as well as a nationwide Danish registry in those with type 2 diabetes, and they looked at the incidence of dementia, and they found that the rate of dementia was lower in those randomized to the GLP-1 receptor agonist compared to placebo in the 3 RCTs, and the rate of dementia was also lower in the nationwide cohort, suggesting that exposure to the GLP drugs may reduce the risk of dementia in those with diabetes compared to placebo. There was recently a retrospective cohort study that looked at 5 million obese adult patients across 73 healthcare organizations in 17 countries. They looked at this propensity score matching, which looked at 103,000 patients in each cohort. One cohort was the GLP-1 therapy individuals and those that were not on therapy, and they looked at the risk of developing a neurodegenerative disease. And in this study, they found a reduced risk for Alzheimer's disease, Lewy body dementia, vascular dementia. They did not find an overall risk reduction for Parkinson's disease with GLP-1 receptor drugs overall, but they did find, looking specifically at semaglutide users, an overall risk reduction for Parkinson's disease. And just published in the last few days is an observational study of 175 health outcomes using electronic medical records from the Veterans Affairs in the U.S. They looked at those with diabetes who initiated GLP-1 receptor drugs versus those with diabetes using another anti-diabetic medication. Overall median of 3.68 years. Those using GLP-1 receptors for their diabetes had a significant decreased risk of 42 different health outcomes and an increased risk of 19 outcomes. They noted in this paper that people without diabetes or obesity were unlikely to experience many of the benefits. They found there were increased risks for gastrointestinal-related issues, hypotension, syncope, arthritis, interstitial nephritis, and a 2.5-fold higher risk of drug-induced acute pancreatitis. But they did find a decreased risk, and you can see the hazard ratios here of Alzheimer's disease, dementia, alcohol use disorder, cannabis use disorder, stimulant use disorder, opioid use disorder, suicidal ideation, attempts or self-harm, bulimia, schizophrenia, and other psychotic disorders, and seizures. So, to conclude, the area in the use of GLP-1 receptor agonists, it's a rapidly evolving field, and there are now a number of approved indications and possibly more to come. There is strong evidence that's certainly worth much further evaluation at looking at Parkinson's and Alzheimer's disease. There's some positive evidence looking at substance and alcohol use disorders and binge eating, in spite of some conflicting results. There's a lack of clear evidence in properly powered RCTs for anxiety and mood disorders. Overall, the GLP-1 receptor drugs seem like promising medications for a variety of conditions, including mental health conditions. They are generally well tolerated and have few serious side effects and are not associated with higher rates of suicide. The GLP-1 receptor agonists cause significant weight loss, which can be beneficial for psychotropic medication-induced weight gain, but may be concerning in some populations, such as Parkinson's and Alzheimer's. The conflicting evidence of randomized controlled trials with the GLP-1 receptor agonists is due to differences in study design regarding sample size, the type of GLP-1 receptor agonist used, and whether they used an obese or a non-obese population. And I'll stop there and like to thank you for your attention.